All right, so we're going to be talking about our approach to angina in 2021. And I've got the Alamo behind me. I am super bummed that we can't all be together in San Antonio as we have been in previous years, but I'm super happy to see folks even via Zoom. And I've got the Alamo, oh, I go this way, and this bagpiper guy too. And that guy's going to be important later. So let's talk. So when we talk about chest pain in the ED, we get super focused on acute coronary syndrome. We have great risk assessment tools like the heart score to help us identify ACS. And honestly, our clinical gestalt is pretty good too. And we've seen that in studies as well, particularly for those of us who have been doing this for a while. So we've improved our ability to recognize ACS. We've even started moving beyond kind of the STEMI and STEMI paradigm, which we're going to come to later. But what about patients who have like coronary heart disease that's not acute coronary syndrome? Okay, how do we diagnose them? How do we manage them? What do we have available to us with that? Because the reality is we don't honestly see a lot of these stable angina patients in the emergency department. They don't really walk in very much. And so what are we supposed to do with these people and what do we have available? So as we like to say at Cook County, and maybe this saying holds true for you as well, this comes up at a lot of our M&Ms, the donut of truth reveals most, if not all good things or bad things. So we're going to talk about the diagnosis of coronary heart disease and angina. And you can see there's a CT scanner here, and we're going to be talking a little bit about CTCA too, or CT coronary angiography. Now, keep in mind, we have risk assessment tools for angina as well, not just ACS. But what do we have that's more concrete, that's more tangible that we can use? So let's talk a little bit about specifically CTCA. So CTCA is an anatomic test. So it tells us about the presence and then the extent of coronary disease. It's accurate, actually. It's usually used in our low and moderate risk patients. Some of you may be super familiar with this modality. Others have never seen it potentially. Now, a CTCA isn't as easy as ordering some of our other studies. Definitely a little tougher than a CT head and a little more complicated than even a CT with contrast, like a CT abdomen pelvis. There's contrast involved, which we're familiar with and comfortable with. We usually like the heart rate to be under 60. So sometimes we have to kind of do that pharmacologically in the emergency department with a little beta blocker. And then the patient needs a little bit of nitroglycerin too to get through their CTCA. So a few steps to get kind of that optimal imaging that we're looking for. What role though does CTCA have in the diagnosis of kind of stable coronary heart disease? Well, the Scott Heart trial, remember the bagpiper you saw in front of the Alamo? So this was a randomized control trial across 12 cardiology chest pain clinics across Scotland. And these patients had been referred to these clinics specifically for the evaluation of stable suspected angina. And after recruiting the patients, they were assigned in a one-to-one fashion to either standard care or standard care plus CTCA. So got two arms to this study. For the purposes of the study, obstructive coronary artery disease was defined as stenosis over 70%. So not a particularly small stenosis, over 70%. And if it was left main involvement, then they kind of dropped that threshold to greater than 50%. And that's what they defined as stenosis on a CTCA. The primary endpoint for this particular study was the proportion of patients that were actually diagnosed with angina secondary to coronary heart disease at 6 weeks. So how did our diagnosis of angina change in the presence of CTCA versus just standard care? So overall, when you take a look at this graph, you can see CTCA helped clarify the diagnosis, which doesn't seem like a big stretch. And you have an imaging modality, of course, you're going to make a better diagnosis. So the 6-week coronary heart disease diagnosis in the standard care group changed by 1%, in the CTCA group, 27%. Okay, so that's a big difference there. And then when you look at the 6-week diagnosis of angina due to coronary heart disease, 1% for the standard care, 23% for the CTCA group. So a good anatomic test that helped us with diagnosis. Now, having the results of the CTCA also changed the subsequent investigations that were planned for the patient. So having the CTCA led to the cancellation of 121 stress tests and 29 angiograms. That's a lot of imaging. That's a lot of resource utilization that we were able to then avoid. Conversely, though, CTCA also led to the addition of 94 invasive angiograms. So kind of in the grand scheme of things, lower test utilization, but it did trigger some other testing that was necessary. So there's a give and take that happens once you identify that anatomy. Possibly most importantly, what came out of the study, the changes in the diagnosis also led to changes in treatment and anti-anginal treatment and preventative treatment. So 4% for the standard care versus 18% for the group that had CTCA. And in terms of the anti-anginal treatment, 1% in the standard care in terms of the delta, 9% for the CTCA. So huge differences in terms of management and treatment in identifying that anatomy. However, there was really no difference between the two groups with respect to revascularization rates or MI and death rates due to MI. So in terms of outcomes, not really a big difference, but in terms of management and diagnosis, a big difference here. So now you take that original Scott Hart trial, and remember, we had outcomes at 6 weeks. They then stretched it out to 5 years. And what did they find after 5 years of following these patients? What they wanted to know was, what was the difference in terms of death from coronary heart disease or non-fatal MIs at that 5-year group between these two, at that 5-year mark between these two groups, the CTCA group and the standard therapy group. Now, remember, the physicians caring for the patients in that CTCA arm were asked to use the results appropriately in the management of their patients. So they should use that anatomy that they're now aware of in terms of guiding their management for their patients. And then the standard care group, the physicians were using an alternate assessment scoring system to drive the management of those patients. So what did we find here? Again, remember, this is an anatomic test. So it helps increase the certainty of coronary heart disease identification, which then can potentially lead to changes in treatment. And as you can see here, the patients who had CTCA had higher rates of preventive therapy at 5 years, anti-anginal therapy at 5 years. So that's great. Not a huge difference. It's not super dramatic, but it's there. They also had lower rates of coronary heart disease death and MI, but again, not a huge percentage. Interestingly, the rates of invasive coronary angiography and coronary revascularization were higher in the CTCA group as compared to that standard group in the first few months of follow-up. But after 5 years, when you push those results, you can see there was really not much difference between these two groups in terms of invasive angiography, PCI, or CABG after 5 years. So here's the issue with CTCA from the ED. It's really reserved for our setting for our low to moderate risk patients. And unfortunately, when it's done in the ED, it's longer ED stays, it's greater resource utilization, it's increased invasive testing and revascularization in the short term, which the follow-up Scott Hart study showed, and without really a great benefit in terms of decreasing subsequent MI or mortality rates. And CTCA itself hasn't really been shown to be better at identifying our higher risk patients compared to other strategies that we're very familiar with, like exercise stress tests or nuclear tests. And also, the CTCA isn't a functional test. So we may identify the stenosis, but how do we use that information and translate that to the functional effects of the stenosis? So remember, ischemia is more than just, a blockage in an epicardial vessel that we can stent. There's also microvasculature to consider. So where does CTCA sit in our diagnostic strategy? It's good to help identify and quantify atherosclerotic disease. You can then help our primary care colleagues in terms of directing the intensity of their prevention strategies through lifestyle improvements and risk factor control. It's not really great for characterizing the coronary plaques to try to figure out which one's going to flick off and cause that big MI and which one isn't. We also know that things like controlling blood pressure, lowering lipids, exercise, diet, these have huge impacts on adverse cardiac events. And so maybe that's where the real value of CTCA lies, in stable angina, in helping the physician and in the patient make those lifestyle modifications that can then improve morbidity and mortality. Now, we mentioned PCI very quickly in terms of CTCA rates. Now, how does PCI in stable angina compare to standard therapy for our patients with stable angina? Now, what role does PCI play? In the COURAGE trial, which was in 2007, the investigators were looking at the effect of PCI on death from any cause and non-fatal MI during a follow-up period of 2.5 to 7 years. So they enrolled a little over 2,000 patients, and these patients all had stable but significant coronary artery disease, and they randomized them to either getting optimal medical treatment or PCI plus optimal medical treatment. What did they find? The ROC scale here kind of says it all. It's pretty balanced, and there was really no difference in terms of the risk of death, MI, or other major adverse cardiovascular events when we added PCI to optimal medical therapy. That's kind of a bummer. So we like to think that taking someone with coronary artery disease and using PCI to open the obstruction should result in improved outcomes like mortality, but COURAGE showed that that's not necessarily true in the setting of stable angina. Now, what about symptomatic relief? I mean, MI and death are very important outcomes that we want to measure, but angina relief is important too, and that's real and that's measurable, and that's probably more important for a lot of our patients. Symptomatic relief can be life-changing for our patients. So along came Orbita. Orbita's goal was to create a blinded, placebo-controlled, randomized trial to identify and measure the efficacy of PCI in stable angina. And specifically, they were looking at the effect of PCI on exercise times in patients with stable angina. So they took 200 patients with severe single vessel stenosis, so greater than 70% stenosis, and angina, and provided optimal medical therapy to everybody for 6 weeks. And then they took half of them and they took them to the cath lab and did PCI. And they took the other half and took them to the cath lab, but they just did a sham procedure. And this is because we know sometimes just performing a procedure on a patient can cause this placebo effect and improvement in symptomatology. And so this is how they really got a placebo-controlled study going. And what they found was that the exercise time in the PCI group improved by 28 seconds. And in the placebo group, by 12 seconds. So the difference between the two groups was only 16 seconds of improvement. So hardly much of a huge effect. And this was, again, another bitter pill to swallow. We like to think that popping open a vessel with a stenosis is going to provide huge symptomatic relief. But like COURAGE showed in terms of mortality, Orbita showed in terms of symptomatology that that's not necessarily the case. So what's the takeaway from these studies? PCI may play some role in patients with severe coronary artery disease who continue to be symptomatic after optimal medical treatment. But the risks and benefits really have to be weighed pretty carefully. So there is an inherent risk in PCI in patients. 4 patients in this placebo arm ended up with a coronary dissection, and we can't ignore that risk. Orbita also highlights another concept that we always need to remember, that coronary artery disease isn't just about the large epicardial vessels, okay, the ones that we can stent. So the microvasculature is also important here. And if it's the microvascular coronary artery disease at play, then no amount of stenting is going to fix that. So what really works? CTCA can help identify anatomy, but not really functionality. It can help change management treatments, but doesn't really translate into long-term changes in terms of morbidity or mortality compared to optimal medical treatment. And PCI doesn't really help improve death or MI rates in stable patients and doesn't seem to improve symptomatology in all comers of stable angina. So we're going to be looking at very specific patients to apply these to. Thanks so much.